you. I'll resume recording. Thank you so much. So we have Dr. Adesola Oniyide, MBBS, MSc, MPH, PhD, and we want to learn so much from the wealth of experience he has gathered over time, years of working in the healthcare system across different parts of healthcare system, both from the education part and from the practice part. So would like to take our time to listen this evening in Africa and anywhere we are in the whole world. We appreciate you for joining. And please permit me to welcome Dr. Adesola Oniyide.
All right. Thank you, Dr. Kolawole, for welcoming me. Let me start by saying good morning, good afternoon, good evening, wherever you are joining this webinar series. I will be speaking on data-driven healthcare system. This will be a series. This is just the part one of this series. As we know, talking about data is not something we can start and finish within, say, an hour of discussion or sharing. Now, what is data-driven approach? Next slide. What is data-driven approach? We know that there are several approaches that one can apply in order to get a result. But when we say data-driven, we're talking about a system where what determines decisions that we are taking will be data that we have collected, we have analyzed, and we have interpreted. So it means that we are not using our intuition to take decisions, but instead, we are using data that we have gathered, we have analyzed, and we are sure that whatever decision we are taking will gear us towards making things better. It is important for me to state that if we move around various health facilities in Africa, we realize that data is not really an in thing in a lot of places in sub-Saharan Africa. And that is a we cannot really be sure if we are really improving or not. And one thing is, we always say medicine and science is empirical evidence. So that is why using data will be a better approach if we are truly interested in driving quality. Next slide. Why do we need to embark on data-driven approach? Why do we need to do that? It is because data-driven approach will eventually change the entire narrative, because it's going to cause improvement in patient outcome. It's going to enhance clinical decision making. And most importantly, it is also going to improve on the value that we get for every money spent. More or less, we are saying data-driven approach is going to reduce cost, because it's going to give us opportunity to look at cost-benefit approach for every dollar, for every amount of money, for every naira, depending on the currency that is being used in that country. We'll be able to juxtapose the amount spent and the benefits that we are getting for the money spent. And the one major tool that we can use is by using an EHR. Next slide. Which is electronic health record. Now, what is an electronic health record? An electronic health record is a version of health record that is electronic, and it contains the patient medical history. Not only that, it contains data on their management, the drugs they are using, their diagnosis. It even contains their demography, their age, where they live, their address. Now, with electronic health record, we more or less have all the data about patients using our facility in one particular place. So more or less, we can easily track what is happening to the patient at any point in time. We can see their progression. We can see if they are getting better. We can see if they are attending clinics. So from EHR, we can determine if patients are compliant on their drug. We will see if they are regular on their clinic visit. And now the fact that we can see all these is one important reason why EHR may eventually be a game changer when we now use that data to take the decision. EHR will produce the data. When we analyze the data, when we interpret the data, whatever decision we take from that will eventually cause a revolution and transformation of the health sector. Next slide. Why should we be passionate about data-driven approach? The reason is simple. Just like I explained, we are going to have all our information in one place. And this will in turn enhance our operational efficiency. It will streamline healthcare operation for maximum impact. Why? Because EHR will give us a digital information about patients, and this will grant us simple access, not only with a digital platform that store information about patients. Loss of file and written file will no longer be a problem. Water pouring on case notes leading to destruction of information about patients will also not be a problem to us. Next slide. A recent study still talking about why it is important for us to be passionate about a data-driven approach if we are truly interested in improving healthcare in Africa. A recent study showed that 92% of healthcare professionals achieve better performance when they embark on technology to drive the health sector. Next slide. From this diagram on our screen, one thing that is obvious, next slide. From the diagram, next slide. All right. Now, from this diagram on our screen, we realize that digitalizing and using data to drive improvement will help us to we work in 4 major areas. Number one is going to be useful in patient risk modeling. So we'll be able to cater better for the patient themselves. So patients themselves will benefit. It's not only patients that is going to benefit, the system itself is going to benefit, because there are 4 important models that we can see here. We have the patient risk model. Apart from patient risk model, we have the clinical model. Then we also have the service model. And now, for patient risk model, the implication will be that we will be able to see what are the problems that are associated with our patient care. Are we getting the kind of result that we truly desire? And the only way that we'll be sure if we are getting the kind of desired result is if we are looking at the data that we have generated. Without data, there's no way we will know if we are getting better results. The same way, if we look at the cost that we are spending in terms of service, we will, based on we will see when patients pay money, because with EHR, it means everyone, all the stakeholders that are in charge of seeing the cash flow, will see how billing is being done, and we can easily trace it because it's in one place based on the data that we are giving. So easily cash flow can be monitored. Not only that, easily we can see how flow of various services that patients need to enjoy within the health facilities are flowing. How patients move from consultation room to the laboratory for their investigation, to the pharmacy to get their drugs. We will be able to see all these movements once we digitalize the health sector and we are using data that we are getting from digitalization. We are not just using EHR just for smooth running, but we are utilizing the data to determine the decision that we are taking. So we know if we need to employ some set of professionals more, or we need to get a particular type of drugs more, or we might need to expand the number of consulting rooms that are available based on the data that we have on our system. Next slide. These are some of the advantages of data. One, we'll be able to see the appointment without looking at the case file. So we can see, okay, let's say today, next week, Monday, we are running cardiology clinic, we are running endocrinology clinic, cardiology clinic by 3 p.m., endocrinology clinic by 10 a.m. We can see how many patients are meant to come. Apart from that, patients themselves can book appointment virtually without having to come to the hospital. We'll be able to track the metrics of patient inflow and outflow. Not only that, we are going to reduce the cost because some activities that initially is being done by human beings, we will not need human beings to do that. Just digitalization will solve the problem. Now, let me share this not very interesting story with us. For doctors that are trained in Nigeria, once you are done, the first thing you do is you embark on an internship, a 1-year internship. And I'm sure that's the situation in a lot of other countries, including the Western world, because I'm aware that even doctors in the UK also embark on internship. But now this is what I want to share with us. In Nigeria, where I did my internship, there's something that is funny. One of the jobs I don't like doing as an intern that time is to be chasing the result of patients. Now, at that center, part of what they make interns do is to be the one chasing the result of patients. Now, if patients are sent for an investigation, let's say a patient is meant to carry out an electrolyte urea and creatinine. Now, it will be a house officer that will ensure that the results get to the case file of that patient. But with EHR, that will not be necessary because the laboratory, once they are done with the result, they just send the result to the record of the patient. Everybody that will need the result, the doctors, the nurses, everyone that are involved in the management of the patient can easily see the result. So that is one advantage. It reduces the cost. In some other facility, instead of the interns chasing the result, they have healthcare assistants that are the one running around, they run from the ward to the laboratory to get the result. But the truth is, if we have EHR, we might reduce the cost. And with data, we will see that if we collect data, we will see that certain responsibility that we are using human beings to carry out, we can actually use computer well managed to carry out those services without having to employ human being. Like, for example, there is no point employing a human being to be the one chasing the record, chasing the result of patient. That can be easily added to the information or the profile of the patient on the electronic health record. Next slide. Another advantage of EHR, which we can benefit when using data, is the fact that it improves communication. Another advantage is that there's a secure database. Like I give that people can lose paper, but if we are focused on having data, and like I have said, there's no way we'll be able to be sure of getting data if we are not using an electronic health record. One major advantage of electronic health record is the fact that we have secured database. So we are not afraid that the record will be lost. Apart from that, with paper, it means anybody can actually carry the case file of patient and start reading. However, if it has been digitalized, the implication will be that there can be password that secure the information of that patient. So it will only be people that are meant to access the patient record that will have access to the record. And with the use of AI, machine learning, we will be able to improve our diagnosis and treatment plan when we have data that we use to evaluate the performance over a period of time. Next slide. In other words, for us to really, next slide, for us to be able to really maximize data, we may need to develop what we call KPIs, key performance indicators. Now, key performance indicators will help us to quantify how we are doing, and we will be able to design programs that will improve operational efficiency. And this time, we are not talking about operational efficiency that is psychological, but we're talking about the one that we can really quantify, that we can see the data to back whatever claim that we are talking about. Next slide. What are healthcare KPIs? Healthcare KPIs are quantifiable or measurable factors that reflect the goals of an organization. So more or less, healthcare KPI are parameters that reflect the goal of the healthcare facility. Working without KPI can create vagueness around performance. We can tell ourselves that we are doing well when we are not really doing well. But with KPI, we can easily compare progress over different periods. And this will make us see if we are really doing well or not. Without KPI, the progress of an organization, in this case, healthcare, over different time can become very difficult for us to measure. Next slide. Now, let's look at some of the examples of data that we will really need if we want to improve the quality of care that we give. There are certain data that we really need. Now, this data may vary from center to center, but I will be sharing the important data that I believe that every center is supposed to have if they are really interested in data-driven healthcare system that we are sure is going to guarantee performance. Number one is admission rate. This KPI measures the number of patients admitted to healthcare facility during a given period of time. Now, this can be done daily. Actually, what I encourage people to do is to have daily admission number. This should be recorded somewhere. Then later they merge it together and have weekly, add the data together and have monthly. So this can be used to determine if the number of patients, next slide, this is very important because it provides insight into the trend in patient volume and demand for the healthcare service. Of course, we don't need to argue with ourselves. If initially we are having 100 patients per day utilizing a particular health facility, and a time comes and the number of these patients dropped significantly, it's obvious that something is going wrong. Either there is a problem with the nature of service that we are getting, or there are unique services that the patient really require and the healthcare facility is unable to provide that. Next slide. High admission rates may indicate a need to increase resources or improve efficiency, while low admission rate may suggest that the patient are seeking care elsewhere or that there is lack of demand for certain services that we are rendering. So like for example, we can now say, okay, because last month admission rate was 50, this month as at almost, this month is almost ending, we are just a day to the end of June, we can say, okay, what is the total number of admission as at this month? And we can do the comparison. So that has given us data about admission rate. Then we can now develop a KPI. But okay, in the next 3 months, we need to increase admission rate by 10%. Now, we can later talk about how to increase admission rate. So, but the key performance indicator will be, okay, on our admission rate, let's increase admission rate by 10% in the next 3 months, meaning by 30th September 2024, our admission rate should have increased by 10%. Next important KPI, next slide, is patient satisfaction score. This is very easy to develop. We can just have a small card or develop a digital form where we ask patients, once they are done with all whatever they need to do during their hospital visit, we can ask them to grade or score the service provided over 10. And if we like, we can break it down. Majorly, what we are looking at is patient satisfaction. But we can say, okay, grade the quality of care you receive over 10. So they have a score for that. How your interaction with the nurses, score it over 10. Your interaction with the staff in the laboratory, score it over 10. Your interaction with the reception, score it over 10. Your interaction with everyone, so we can list the people that patients are going to encounter and ask them to score it over 10. Then we now ask them, they should give an overall score as far as patient satisfaction is concerned. Now, if we have this kind of data, we can now look at, in the last 3 months, what is the average score that patient is scoring our facility. Last month, what was the score? Now, as of today, what is the score? Now, this gives us opportunity of real comparison of patient satisfaction that is based on data. And with this, we will be able to take decisions that will really improve patient satisfaction. Next slide. This is an important metric, just like I have explained. It will help us to check if patients are really getting quality care that we want them to get. And this will move our center to patient-centered care. So it will not just be a health facility, but it will be a health facility that is patient-focused, ensuring that patients are getting satisfaction. Now, let's say we realize that the average score for patient satisfaction has been 5, 6, 7. We can now say, okay, we want to, or let's say we are scoring it in percentage. Like in this slide, let's say we are scoring it in percentage. We can score it 1 over 10, and we can score it in percentage. So let's say when we look at the average, we realize that it was 75 or 60 3 months ago, and now it is 80. We can have a target that in the next 6 months, we want our patient satisfaction to rise to 96%. So that's another way we can use data. This patient satisfaction score is very, very important. In fact, is like the litmus for the quality of care that we are giving patients in health facility. Next slide. Another important data that we need to keep if we really want to improve the quality of care that we are giving is patient complaint. And there should be a patient complaint form, either digital or on paper. Usually, I always encourage digital, and this can be done by just filling a form. Although I'm aware that a lot of patients in this side of the world may not even have a phone that will be able to do that. But a simpler approach for doing that will be that we have an official that can easily convert whatever form that they fill manually, input it digitally onto the system, so that we can have the digital record. So patient complaint, we can ask patient what they don't like about the service they received, and we can develop a KPI by saying we want to decrease patient complaint by 25%, so that let's say this month, or let's say last month, the number of patients we complain was 100. We can say, okay, in the next 6 months, we want to reduce the number of patients with complaint to 75. So that way, we have reduced patient complaint by 25%. Now, the reason we know this is because we have a record for patients that are complaining. Next slide. Another important parameter, next slide. Another important parameter is average patient wait time. I'm sure all of us here, we agree with me that there is nobody that likes to wait. Everyone don't like to wait. Everybody like to be attended to immediately they get to where they are supposed to get a particular service. I remember before now, part of what I don't like to do in the recent time is going to bank. With the mobile digital banking, I'm always very happy. I am always thinking anytime I need to go to bank. And the reason is simple, is because of the wait time. So that's the same way that patients don't like to come to hospital and wait. So average wait time is another record that we need to keep. And this record will be very useful when we need to re-strategize in order to improve the quality of care. Next slide. Patient wait time can be calculated by finding the average amount of time patient moment that they are being seen, receive their drugs, and eventually leave the healthcare facility. The average patient wait time is very useful KPI. The average patient is very useful, and we can set a target like I want to increase patient wait time. Let's say it takes 1 hour for patient to wait before they eventually see the doctor. We can say we want to reduce that by 10 minutes. But it is important. In fact, my emphasis here is the fact that we need to collect these data first, review them regularly, so that we can use this data to determine what we need to do to improve on our care. Next slide. Next slide. Next slide again. So another important data is bed occupancy rate. Bed occupancy rate. Now, bed occupancy rate is very important, so that, let's say for example now, in a major secondary healthcare center, we have pediatrics unit where they take care of children. We have obstetrics and gynecology unit. Under the obstetrics and gynecology unit, we have the gynae ward, gynecology ward. We have the obstetric ward. We have the labor ward. Now, all these our wards do not have the same level of utilization. Bed occupancy rate is the proportion of hospital bed that is in use at any point in time. Bed occupancy rate is a good indicator of hospitals' ability to provide safe and effective treatment to patients. Now, if we have an hospital where most of their beds are empty, it means that patients do not like the kind of service, the kind of care that particular health facility is providing. That's the implication. Now, this bed occupancy rate, if an hospital's bed is always full, it also means that there is need for the management to think of expansion, because in a short time, they will need to start sending patients away. Not only that, if the bed of an hospital is always full, it's also an indication that they need to be sure that the doctors, the nurses, the pharmacists, all the people working in that facility are not being overwhelmed, because it means that that particular facility is being utilized maximally. So they need to be sure. Now, this bed occupancy rate is important to know where we also need to do the expansion. Like, for example, let's say it is the labor ward that is always full, while there are always empty beds in the orthopedic ward. It means next time that we are thinking of expansion, the focus should be to expand where they need more beds. But if we are not tracking this record, it will be the day that we no longer have bed for patients that we suddenly realize that. But if we are tracking the record, we'll have seen the progression that 3 months ago, we admitted 1,000 labor ward, 1,000 patients into the labor ward. 2 months ago, we admitted 1,200. Last month, we admitted 1,500. As of today, this month, we have admitted 1,600. This will give us a direction on the kind of decision we need to take. So we know that if we are employing nurses, we should employ more obstetric nurses because we have more obstetric patients. If we are employing doctors, we should employ more obstetricians. So this way, we are using bed occupancy rate, the data from bed occupancy rate to drive the type of decision that we are taking. And that way, we will be able to get better results. Next slide. So on this slide, I said, therefore, bed occupancy is a great key performance indicator for measuring operational capacity objective. Once the KPI measure is tracked, healthcare provider can estimate whether or not to create more bed space, and also the type of bed spaces to be created and the kind of staff, be it clinical or non-clinical, that we need to be employed. Next slide. Next slide. Average hospital stay. Next slide. Just as the name implies, this KPI track the average length of time patients stay within the hospital. Why this metric is very useful, it's also very general. Using average hospital stay as a single KPI to track all different categories of stay in your facility won't prove to be very helpful. Like, for example, when using average hospital stay, what will make sense will not just do a generalized average hospital stay, but average hospital stay based on diagnosis, based on treatment. Like, we can compare average hospital stay of patient being managed for stroke, average hospital stay of patient being managed for fracture, average hospital stay post appendectomy when there's removal of appendix secondary to suppurative appendicitis, average hospital stay after childbirth. So now, is those parameters that should be compared with each other, not comparing average hospital stay of a woman who delivered a baby to average hospital stay of a child that is being managed with tetanus, or of a man being managed for hypertensive emergency. So we need to, for this average hospital stay to be helpful, we need to compare parameters that are similar. Next slide. Just like I have explained, the recovery from heart surgery will almost be longer than from somebody who had cataract surgery. So that means for us to utilize this average hospital stay, we will need to compare parameters that are similar. Next slide. Staff to patient ratio. Now, this staff to patient is an indicator that measures the number of staff resources present to attend to patients in an hospital over a certain period of time. Now, just like I said, if you look at the nature of patients that are using the hospital, that will also help us to determine the nature of staff that we will need. Or else, we will have a situation that is very common in a lot of West African countries, where some specialists do not have enough patients. So more or less, they are just enjoying themselves in the hospital. While some others are being overworked because we employ equal number to manage unequal number of patients. Like for example, we may have, let's say, a unit that is having patronage of say 5-10 patients per day, and we now employ 10 doctors in that unit, and another unit that is having patronage of about 100 patients per day, we also employ 10. So one will be enjoying while the other will be overstretched, and that will in turn affect the quality of care that patients are going to receive. Next slide. This KPI may require different ratios. That's what I just explained, for different periods, such as morning shift versus night shift. We cannot put the same number of patients in morning and night shift. And we should break down this staff patient ratio accordingly, so that it's going to meet the demand and ensure that we are able to deliver quality care. Because if we do not break this down accordingly, we are just employing arbitrarily to improve the staff patient ratio, we might still not be able to give quality care. So more or less, we should employ doctors that we really need, nurses, we employ professionals that we really need, so that we are going to eventually achieve better care. Next slide. The highest staff to patient ratio implies a greater capacity to provide treatment and care. And we can always track this record. What is the patient staff ratio last year, 6 months ago, 3 months ago, and now? Now, next slide. In Nigeria, I just brought this data. In Nigeria, the pressure on doctors and nurses are so much. In fact, it's part of the reason why a lot of health professionals are leaving West Africa to the Western world. Sometimes it's not just because of the pay, but because of the pressure. The workload sometimes is too much. World Health Organization has recommended between 1 to about 2 to 400. And Nigeria is looking at how to achieve 1 to 600. But as at now, the current situation is 1 patient to 2,753, 1 doctor to 2,753 patients, compared to the target of 1 to 600. Now, this indicated that a lot, like for Nigeria, still need large deficit of doctors, nurses, and other health professionals. And I'm sure this is the same situation for a lot of other African countries. Next slide. Medical equipment utilization. I cannot forget an incident that happened while I visited the primary health care. One primary health care I was visiting, then I realized that they do not have any doctor in that particular healthcare facility. The healthcare facility is being managed by the most senior matron there, the most senior nursing officer there. But what surprised me is the fact that despite the fact that they don't admit preterm baby, one displayed, the remaining 2 in the carton. And there are other health facilities, although not in that particular town, but in the same neighborhood, that have doctors, nurses that can take care of preterm, but they do not have incubators. So that is showing us that it is very important that we keep record of medical equipment utilization, so that we will know if some equipment is to be moved to another facility and we need to buy another equipment, so that we can focus on equipment that is in high demand, so that we will not just waste money in buying equipment that will not be used. Very, very important. This KPI is very important, so that will help us to determine the nature of equipment that should be purchased for health facility in order to improve the care that patient using that facility can get. Next slide. And the equipment that are in use, we can now say, okay, how can we make it more useful? How do we create awareness that this particular equipment is present here so that it can be utilized more? And we can have KPI, like example, increase medical equipment utilization by 15%. I always suggest that we can break it down. Increase utilization of our CT scan by 15%, increase utilization of our MRI, increase utilization of our digital X-ray, of our ultrasound, of our ECG, of our EEG, and so that we can measure progress that we achieve with respect to medical equipment utilization. Next slide, patient room turnover rate. This KPI measures the amount of time it takes to prepare hospital room for the next patient after previous patient has been discharged. I can also not forget one private hospital where I used to work, that it is when we inform the people that are meant to admit patients into the ward that they begin to run around to get the ward ready. That's not supposed to be. Room should be ready once patients are discharged. So that means we can measure this. How long does it take for the room to be ready for use by another patient after the discharge? And now that will help us to measure how effective the health attendants and the cleaners are doing their job. So we see how effective they are in getting the room ready. That will help us to decide if they need to get better training or they need extra hands in order to ensure that the room turnover rate is appropriate for what we will need. Next slide. A high turnover rate indicates that the facility is effectively managing the patient flow and minimizing the time between patient discharge and admission, while a low turnover rate may indicate inefficiency of the facility's operation or staff. So we can say we want to reduce room turnover to 30 minutes. Let's say it's taking us 2 hours. So we can look in the last 6 months how long. But if we do not have this data at all, how are we going to measure? So that is why data-driven health quality improvement is not something that we can overemphasize. There is no amount of talk that we give on this particular subject matter that we can say it is too much. There is none, because it will really give us the opportunity to do proper evaluation. Next slide. And now, next slide, as I'm rounding up. One important thing that we also gain when we are doing data driven, we're able to do financial analysis. We're able to look at cost benefits. We look at how what we are spending is beneficial to the patient that we are serving. So with this, I've come to the end of the part 1 of this presentation. The next time, I will talk about how we can collect the data, how we can represent the data, how we can analyze the data, and how we can make some inference from the data, and how we can use the data to plan to improve the quality of care. I must thank you for your patience listening to me. I believe you must have learned something, and I want to encourage us to put whatever we have learned to use. Thank you so much.
Wow, thank you so much for that awesome session. That's detailed, and hopefully would get more from the next session. At this point, I would like to open the floor for questions. If you have any question, please, this is the time to, you can send it via chat. If you don't want to unmute and speak up, you can send your questions via chat, but please, let's ask questions, please. I can see Dr. Lucky Omowara, Dr. Dennis. Please, let's ask question. Thank you for the present. Thank you for your comment, Dr. Lucky. Okay, so Dr. Adesola, there's a question in the chat for you that says, what's the difference between the admission rate and the bed occupancy rate? Maybe you can shed more light on that.
Okay, I'm thinking, can we take all the questions together so that I can save the time?
All right, then let's see if we'll get more questions and then.
Hello?
Hello, who's that,
Good
please?
evening,
Just
everyone. Good evening,
Good
everyone.
evening.
good evening, thank you.
So my next two questions, I think I'll rather ask than write. Now, part of the key, thank you very much for the presentation. It was actually, today's presentation has made me know that I'm not wasting my time here. So now, my questions. Part of the key performance indicators, admission rate was there, right?
That's
Yes,
correct.
Now, for tertiary hospital setting and teaching hospitals, the clinic, the outpatient department is also a very, very, very important aspect of the
Very
hospital.
correct.
So why isn't there something like maybe turnover of patients for clinic or how many patients come to clinic? Why is it not part of the key performance indicators?
It is,
So
it is actually. It is. I just gave examples. I did not exhaust. I just picked this out of the key performance indicators that I generated. This is just like 35%. What you
okay.
mentioned is part of the key performance indicator. You remember
Okay.
at the beginning, I said these are examples of key performance indicator that different centers will generate key performance indicator that will suit the goal of that particular facilities.
Okay. 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 Thank you. Then the third question is actually not from today's presentation, it's from last week's own.
Okay.
When we're talking about health output data, and then the parameters that were measured and compared between Nigeria and other countries. So now, infant mortality rate was mentioned, maternal mortality rate mentioned. So, and these are rates that we're actually very familiar with, when we're talking about health. But is it exhaustive? Because we have not talked about, for example, maybe like men's health. We have not talked about maybe like the geriatric population. So was that just an example? Those two, were they just examples? Are there more? I don't know whether you understand my question.
Can you please repeat the question?
Okay.
Thank you. I think I understand the question, if I can come in.
Okay.
So just like Dr. Oniyide mentioned, those data were not exhaustive too.
Okay,
Improvements are usually tailored to the goal of the institution. Sometimes what determines the data that you measure or the parameters that you pay attention to are usually related to the goal you hope to achieve or you plan to achieve in your facility. Most times, improvements spring up from maybe challenges that people are having in their facilities. And the key parameters that they will love to measure and they will love to improve on will be dependent on the challenges that they are facing at that point.
Okay.
Thank you. I hope I answered your question.
Yes, you did. Thank you.
Yeah, thanks for that question. Can I chime in a little bit as well? Most institutions have strategy sessions, and when they get to those strategy sessions, they discuss challenges, right? But they also have donor partners, and they have government funding that are directed towards some initiatives per time. All these informs what they actually pay attention to per time to actually measure. I can say maybe technically and maybe unfortunately, nobody really cares about the population of men, and no one really wants to fund men notable healthcare system, because the women and children are very, very good proposals when you really need to raise funds from donor agency. So you may have more data readily available for those. I'm careful because I don't want to use vulnerable population for men and women and kids. But I think technically in water zone and all these during pandemic, we tend to prioritize them more. So because of that, we may have less data showing for men and maybe for geriatric population in Africa. So maybe that's just another perspective. And then don't also forget, there's also root cause analysis being done when they are trying to reprioritize and refactor how resources needs to be spent and all those things. So just a little this thing from my end.
Okay, so my last question is in the chat.
Or did you just type it, or I'm the one I typed?
No, it's the one I sent it before asking these questions.
All right. Now, let me add to what Dr. Kolawole just said. Now, like what the question
I'm not sure.
part of what data will also do for us is that part of what data will do for us is that it will also open our eyes to see subgroup of patients that are being neglected, just like you have said. By the time we are seeing data and we realize that there's no data for elderly, then we start asking questions. How come that we do not have any data for elderly? And that, in a way, also will cause us to start thinking and probably create something that will also meet the need of those category of people. Those are part of that's why we may not be able to exhaust the usefulness of data-driven healthcare system. Now, let me answer the other question, difference between hospital admission rate and bed occupancy rate. Now, hospital admission rate is measuring the number of patients admitted over a period of time. Like, for example, I can say this week, we have admitted 10 pediatric patients, we have admitted 50 obstetric patients, people admitted to deliver their baby. We can say, okay, we have admitted 2 hypertensive emergencies, we have admitted 3 diabetic emergencies. Those are admission rates, hospital admission rates. Now, bed occupancy rate is now talking about the proportion. You know, all these admissions will eventually get into the ward and they will be on our bed. But bed occupancy rate is now focusing on what percentage of our bed is being used as a result of this admission. Do we get? So we are saying we are in total, we have admitted 200 patients this month. And these 200 patients eventually at different points in time utilized 50 to 85% of the hospital beds that we have. So that bed occupancy rate is looking at rate of utilization of the bed that is in the hospital. You realize by WHO, we usually define the capacity of hospital by the number of beds. They like saying a 250 bedded hospital, a 120 bedded hospital. So bed occupancy rate is now looking at what proportion, what percentage of the bed in that hospital is being utilized as a result of hospital admission. I hope I've done the clarification.
Yes, thank you. That was clear.
All right, I added in the chat AHRQ website, NQF website. They are both American-based website. They've worked over the years to create standardized indicators that you can use for measures in your hospital. So that cuts across and I'm talking AHRQ is Agency for Healthcare Research and Quality. And I think NQF is National Quality Forum. So if you log on to their website, you can find your way around to their patient safety indicators. It will take you to the measures, and then you can leverage that to understand all forms of measures across any form of disease you can imagine. Work has been done on them. You will see some measures that have even been retired because they are no longer valid. And by validity means by the time you test them over time to ensure that they actually can peak closest to what you want to measure, they do not. And so they have to be retired and newer indicators have to be created. So in case you want to explore more about today's topic, you would find those websites useful.
Okay, thank you.
You're welcome. Any other question? We still have a couple of minutes before we wrap up today's class. I'm sure it's been an interesting time. And thank you for that feedback, Mrs. Oile, saying this has really, really been worth your time. And hopefully, as we continue in the series, we'll be doing bi-weekly sessions, bi-monthly sessions. That's twice every 2 weeks going forward. And we'll be bringing some guests across the world now, global guests, to also come and talk to us. We'll be doing what we also call two model presentation, where you have two speakers either interviewing or interacting with one another. You can throw in your question, or we have different models of learning as we keep evolving. So the International Institute of Healthcare Leadership and Quality Assurance is focused on transformation, and the goal is to get all healthcare professionals across different spectrum in Africa to become transformational leaders. We say it this way generally. Until we're able to get everybody to be trained as an assessor themselves, it's difficult for us to drive quality improvement as a system in our facility. So that's the goal. It's something that is evolving gradually, and we would want you to also get more of your colleagues invited to believe in the system and to get more people on the WhatsApp platform. We're hopefully targeting that by the end of the year, we have about 1,000 people on the WhatsApp group. We probably may move to Telegram if WhatsApp cannot render that. But the goal is to drive system, and we're already working with various other global organizations seeking for partnership, for grants, for different kind of models to drive outcome-based learning and to drive project-based learning, as it were. So this is an organization that you would want to be a part of. You would learn, you would grow, and you would also be able to network, which is a key factor in transformation. The collaborative advantage that comes with leveraging the minds of many other people to gather experience that might even take you a lifetime to get. But if you can leverage those networks to gather those experience and compress them within your own short time, you could leap and have like 10 lifetimes in one. And that's the goal. So we're given to transformation in healthcare, and that's the drive that's keeping us going. So would like you to invite more people onto the group, and then to also let's take this further. So would have another session in 2 Saturdays time, and then of course we would communicate all the details on the WhatsApp group. But please, if you have any question, I can see Dr. Musango. I see you've been consistent. Dr. Loki's been consistent. Ms. Bomio Yele, you've been consistent. I would like us to put where we are joining from, because for these 3 names, I think we would really need to do some giveaways at this point. One of the things we'll give is maybe a soft copy of my book, and then would make sure we provide an electronic copy of like a certificate that shows that you attended this training, and it will carry some 2 CE points, that's continuing education point, just to encourage us, one, and then more importantly, you can use them for your registration renewals, and then to also show friends and colleagues that you've been joining a transformative session, and we promise to make it more interesting. Over the course of the week, we also interacted with other professionals across the world in the United States here, and a lot of them are already giving their voice and their commitment to it. One of the people is Dr. Beatrice Marcel. She has a PhD from Johns Hopkins Bloomberg School of Public Health, and she's given a this thing to also join and be a partner with on this program. And so we're looking forward to getting more internationally recognized people that we're talking with. So thank you, Dr. Musango. I see you're in Abuja, Nigeria. So what you should do for me is on the WhatsApp group, just locate my number and just give private chat me. We'll make arrangement on how a copy of the book will be delivered to. If you're in Nigeria, I would like to send you a hard copy. But if you are not in Nigeria, I probably would send you a soft copy of the book, of the material. And the book also has a workbook that is available as well. So Dr. Lucky also is in Warri, Delta State, Nigeria. Oh, Abuja. Oh, it's great. Okay, thank you so much for sharing that. So please, you can just DM me on WhatsApp, and then I'll connect you with how you would get a copy of the book sent to you. But please, just like I said, we need more people to join the WhatsApp group. Let's talk with our colleagues, with friends in our workplace. If you could give me just a few minutes, I'll stop sharing, but I'll reshare in a bit. Just give me a few seconds. I would just like you to see a slide before we go, and then from there we can wrap up if there is no question. But if there's any question, please feel free to start typing or to unmute while I just look for the slide I want to share. Thank you. All right, so I'll be sharing the slide just right away. I don't have any chat in the group to ask for any question. Okay, just a moment, please. Let me share my screen. Yeah, so there are many, if you can see my screen, there are many justifications for why there's a urgent need for transformation in healthcare. And by transformation, I mean a fundamental rethinking, reanalyzing the way we program our healthcare in Africa. Our market is technically way different from the way the healthcare market in the United Kingdom and in the United States, or maybe even in Canada and Australia, has been built. If we look at, if we evaluate our data across this 9 spectrum, we would see tremendous reason why we need to quickly build leaders who are capable of going back to the drawing board and strategically redesigning the system. When we talk about our healthcare outcomes, the infrastructure we have, the access and equity of care across various spectrum of population, ranging to policy and governance because of our time. All these shows the urgent need for us to transform our system. That is, to go back to the drawing board and redesign something different. But we can't do this unless we have leaders who are built with the competence that is needed. And so our goal is to ensure that both from student level, the International Institute of Healthcare Leadership and Quality Assurance, we're trying to offer a distinctive form of leadership education that would drive transformational leadership as the forefront, because when we are able to get that, we will get people who have strong ethical leadership, we'll get people who are intellectually stimulated, we'll get people who are inspired and motivated, and then we'll get people who are driven by compassion to change the system. And so more importantly, this institute is focused on both student and health professionals across these fields: medicine, nursing, pharmacy, med lab science, optometry, physiotherapy, radiography, healthcare administration, healthcare IT project management, and so on. So I'm just using this tentative slide. This is not a finalized document, but just for you to see the progression of things, and now you can also be a part of this growing idea, and then open to be able to serve you more along the scope of this. So please, this is beyond just one person. This is something that we would like all our collaboration and would want every one of us to work together. So I can see, I think Dr. Sherif Ojulari on the call. I can see others. So would like to integrate efforts to work together and then be able to redefine the African template or the African landscape for transformative education. So that's actually the drive. This is the vision and mission. We also have a website. I can drop the website again on the chat. It's been dropped a couple of times before, but the goal is for us to be able to lead something transformational for healthcare leaders. So as it is, we'll continue with this learning session and then would update you on all basic details on the WhatsApp group. But I want to appreciate you for joining today. Thank you so much. So if there is no other question, what we'll do is after about 2 or 3 hours from now, when Zoom has rendered this video appropriately, this will also be loaded on the channel for the institute. That's the YouTube channel for the institute, and I'll make sure it's uploaded immediately. And once it's uploaded, I'll probably drop the link on the group so we can also share with our friends, with colleagues, and with people you think would benefit from this class. And since this is a series that Dr. Adesola Oniyide has started today, we hopefully think multiple series would happen. But I want to appreciate every one of you for taking time out to join this, and hopefully we believe we'll get more people to watch the recorded session, and then in subsequent sessions we'll get more people in July. So I believe second Saturday in maybe the next this thing will be in 2 weeks time, and the link will be shared on the WhatsApp group. Thank you so much.
All right. Thank you, everyone. Have a beautiful evening.
Thank you all. Good night.
Thank you.